Hello, and thank you for joining me for my presentation. My name is Kevin Johnson. I'm a doctor of physical therapy and therapeutic pain specialist. As you can see, my presentation is going to be on how understanding brings freedom, a new way to address pain. Why did I choose to become a therapeutic pain specialist? In 13 years of being a physical therapist, I have seen hundreds of individuals who have not benefited from the standard care provided by medical professionals for chronic or persistent pain. Imaging, injections, surgeries, exercise, medications, manual therapy, modalities of every kind, biomechanical evaluations and corrections, postural examinations and education, and the list goes on. Some relief is provided through many of these treatments, but it is almost always fleeting. I was introduced to what I see as a better solution to help this population when I took a course on Therapeutic Neuroscience Education in Grand Junction, Colorado by Emilio Puentedura. This opened my eyes to a new way of treating individuals with persistent pain. My goal with this presentation is to change how my fellow practitioners approach pain education with their patients and pique their interest in learning more about pain neuroscience education. Being honest with ourselves is sometimes the most challenging thing. How do we talk to people who have persistent pain? Any of these conditions would apply. How good are we at educating patients so they leave feeling empowered after they have been given these diagnoses? We must be cautious not to be roadblocks in our patients' path to recovery. Each moment patients spend with a healthcare provider has the potential to be life-changing. Whether that be positive or negative is partially up to us. If we educate our patients effectively, they will develop greater physical and psychological health, leading to improved results. How do these images affect us and our patients? As Franklin Delano Roosevelt said, the only thing we have to fear is fear itself. Images and words can create fear. Terms such as arthritis, herniated or bulging disc, bone on bone, bone spurs, spinal stenosis, scoliosis, and impingement can exacerbate symptoms. Even terminology that seems benign to those without pain issues, such as tightness, laxity, or the word pain itself, can become provocative to those with chronic pain. As I explain that muscles move bone and joints and that ligaments hold bones in position, this offers some comfort to help calm fears of backs going out. Explaining that transverse foramina are 3 times as large as the tissues running through them can help calm fears of nerves being pinched. First, do no harm. I see creating fear as doing harm to the nervous system by affecting our thoughts. If it makes a difference in the patient's mind, it will make a difference in how they feel. The nervous system controls everything in the body, and our thoughts control our nervous system. Here's an example of how the brain can be deceived. Can you see the difference between boxes A and B? They look like they are different colors or different shades to me. I probably couldn't convince you otherwise. This study indicates how the mind works. Our mind perceives things differently than they are in an effort to make sense of the world around us. Until the external noise is blocked out, the mind will always say that the boxes are different colors. Once we block out the surroundings, the truth can be perceived. By connecting the 2 blocks with the path of the same color, it's easy to see that they are indeed the same color. To me, B still looks a little lighter than A, but that's because of its being in the shadow of the cylinder and is surrounded by darker blocks, and my mind won't allow me to perceive how it really is. How does this relate to pain? Pain is a perception by the brain of information it receives from its environment and its body. When the perception is that there is threat to the system, pain is created for protection. In this diagram, it is reinforced that structural changes are normal and pain doesn't have to result from these changes. Think about the effect this information can have on someone and how it can take away their fear to be active. Activity is at the center of rehabilitation, and when they feel better, they will move more, experience less pain, and potentially regain their lives. We have been focused on pain for a long time. We need to move beyond pain as the fifth vital sign. By focusing on the pain, we often magnify its intensity. Our systems have the ability to reduce pain in many ways. The body produces endorphins that are 50 times as potent as any painkiller that can be prescribed. This is not pain management. This is pain rehabilitation. We can make pain better by teaching our patients they can overcome their fears and experience lasting relief. Here's a quote by Adrian Lowe, one of the lead researchers in pain treatment. He states, "Pain neuroscience education has the potential, when combined with the appropriate movement-based strategies, to change both patient outcome and clinician outlook, which may ultimately prove invaluable to society. Thus the heuristic, no pain, no gain." Here we have a diagram of the mature organism model, which was invented by Louis Gifford, a pioneer in the study of pain neuroscience. This demonstrates how messages coming from our environments and tissues travel to the central nervous system. Here the brain scrutinizes the information it receives and then decides what response is most appropriate. This results in altered behavior and physiology, especially when threat is perceived. For the sake of humor, I'm going to relate some stories from the viewpoints of my young children who have an immature organism model. When their brain perceives a signal that they've stubbed their toe, they feel pain and do what helps it feel better based on previous experience of similar injury. This may include shouting, crying, limping, rubbing the toe, and maybe even having mother's magical kisses applied. It's amazing how magical those kisses can be and how pain just disappears instantaneously and the screaming stops with it. Think about that for a minute. Placebo is the most powerful and consistent remedy out there, because as awesome as my wife is, I don't believe she has magical kisses that eliminate pain. All of our senses are 100% perceived by the brain. Our ears don't hear, our tongues don't taste, our eyes don't see, our noses don't smell, and our tissues don't feel. All of these tissues have receptors which relay messages to the central nervous system. The brain perceives the signals, receives the signals, and determines all of our experiences as it interprets the information it receives. So, can we be injured and not know about it? Of course. The brain decides when we will feel pain, and if it is busy processing something it deems more important, we may not feel any pain when there's an injury. Think about rolling your ankle when crossing the street and you notice a bus is about to hit you. The danger signals from the ankle will be ignored until you are safe. Pain might impede your ability to escape the bus, so its creation would not be useful in that situation. Can we feel pain without being injured? This is where we get into an understanding of pain without input from the peripheral nervous system. Think of phantom limb pain. There's no tissue, but the brain's map of the body is still present and active for that body part. If it's cold outside when you sprain your ankle, it's possible the next time it's cold outside you might feel ankle pain. Past experiences directly affect future sensations and protective mechanisms of the mind. The brain is fascinating, powerful, and our understanding of it continues to increase. As I just talked about, pain is a perception for protection. If it is present, we know about it. Pain is the cortical output of highest priority. there is an increase in the conviction of the central nervous system that body tissue is in danger, and therefore there is an increase in activity of the pain neuromatrix. Multiple areas of the brain are involved with the pain neuromatrix, just as multiple parts are involved with the memory of a loved one. It is impossible to isolate the areas involved. If you think about a loved one, you will often hear their voice, feel their touch, and experience a sense of attachment even long after that person is no longer in your life. As you can clearly see, many areas of the brain become activated when danger is sensed and pain is produced. Pain is complex. Explaining it can be challenging, but we owe it to our patients to give them the most up-to-date information that we have available. Pain neuroscience education has been shown to be very effective in treating a myriad of complex pain conditions. This is where a multidisciplinary approach is most useful. I can't prescribe medications for illnesses or administer injections or perform surgeries, but I can help make these interventions more successful through ensuring correct understanding of pain. The rest of this presentation will help you understand the process I will use in educating and treating patients. Meet Marie. This is her body diagram, which she completed as one of her intake forms. Marie is a 60-year-old active female who was in a motor vehicle accident more than 2 years ago, where she was hit from behind at about 10 miles per hour by a dump truck when at a stop sign. She is now experiencing spreading pain that began in her neck, but now she feels it in both arms, the left shoulder girdle, both upper trapezii, and both ankles and knees, though these symptoms are different from those in the neck and upper extremities. She is sure that the motor vehicle accident is the cause of all her neck and upper extremity symptoms, as she didn't have any of these symptoms before the accident. Marie explains that she did not feel as if she was listened to by other providers when she told them her pain was spreading. She has seen many health specialists, osteopaths, chiropractors, massage therapists, physical therapists, and has considered going to a pain clinic, and has noticed diminishing benefits from all treatments that she's received. In fact, her pain seems to be getting worse. Currently, Marie notes that her pain is a constant 6 out of 10. She appears to be anxious and speaks rapidly, but has to stop every now and then to catch her breath and change positions to calm her pain. Marie states that the only thing that helps her pain is ultrasound, and that is all she wants to have done to her neck. She is fearful of having her neck touched or her head move. She mentions that any movement, either passive or active, seems to cause her extreme pain. She pulls away and complains of pain with gentle pressure on the neck. While speaking with her, she is obviously irritated when she speaks of the motor vehicle accident, which happened more than 2 years ago. She expresses hopelessness of her condition and how it has changed her activity level and led to a 20-pound weight gain. She just wants to get some relief so she can get back to doing some of the things she used to do, such as hiking, working, and enjoying her grandkids. Her physical examination indicates weakness in her hips, delayed activation of her deep core stabilizers of her cervical and lumbar spines, and blunted bilateral patellar tendon reflexes. She is very tender to palpation in her cervical spine and her left scapula.